Okay, good morning, everyone. Welcome to Wednesday morning rounds. Please remember to sign in next week or register for next week. We have a visiting guest from the University of Calgary, Dr. Robert Miller. So please sign up. There'll be announcements going out from Carrie's office. So it's my pleasure today to introduce Dr. Kadoya. He's one of our cardiac imaging fellows. He completed his MD at Jishi Medical University in Japan and completed his PhD at Kyoto Prefectural University of Medicine, where his research focused on MIBG imaging and TAVI patients. His current work here at the Heart Institute includes a randomized controlled trial of inspiratory muscle training, which was supported by a CHR research fellowship. So today he's going to talk to us about coronary microvascular dysfunction, invasive and non-invasive assessment. So welcome.
Good morning, everyone. Thank you for coming here today. So I'm Yoshito Kadoya, one of the cardiac imaging fellows. Thank you for having me today and for the kind introduction. So today I will be discussing coronary microvascular dysfunction. So I have no COI disclosures. So this is today's outline. So first, a brief overview of coronary microvascular dysfunction, and then pathophysiology, an invasive and non-invasive assessment, and finally, I will touch on treatment of CMD. So this slide shows the coronary macrocirculation, which is essentially the visible coronary arteries seen on coronary angiography. So historically, we used to diagnose and manage ischemic heart disease based on the coronary angiography findings. However, we recently recognized that coronary microcirculation plays an important role in terms of symptoms and outcomes in ischemic heart disease. So now, what is the coronary microvascular dysfunction, CMD? This is a patient information article published in JAMA. So they define it as abnormal dilation and constriction of the coronary microvasculature. It is also mentioned that most people with CMD are women, and the risk factors for having CMD are hypertension, diabetes, dyslipidemia, smoking, and autoimmune disease, as well as previous treatment of breast cancer. So then, what is the pathophysiology of CMD? So coronary arterial circulation consists of two main components, the epicardial arteries and the microvasculature. So epicardial arteries are the conductance arteries that typically larger than 500 micrometers in diameters. Under normal condition, these epicardial arteries contribute only 5% of the total coronary vascular resistance. They only become hemodynamically significant if there is more than 50 to 70% stenosis. The coronary microcirculation includes the pre-arterioles, intramural arterioles, and capillaries. So these small vessels are responsible for more than 90% of coronary resistance under normal condition. So the microcirculation is crucial in regulating myocardial blood flow in response to metabolic demands. Essentially, myocardial oxygen extraction at rest is near maximal. So any increase in oxygen demand must be satisfied by an increase in coronary blood flow. So this is achieved by vasodilation of these microcirculatory vessels, and it allows coronary blood flow to increase up to 5-fold. This is a diagram showing the multiple mechanisms behind CMD. So simply put, functional changes, structural changes, or a combination of both. The functional mechanisms include impaired vasodilation and or increased vasoconstriction. So impaired production, impaired vasodilation is associated with endothelial dysfunction, which involves reduced production or increased breakdown of nitric oxide and other relaxing factors released by endothelium. The endothelium-independent mechanism is less understood, but it is believed that impaired relaxation of vascular smooth muscle cells is involved in vasoconstriction. Also, microvascular spasm is a part of spectrum of vasomotor abnormalities seen in CMD and is closely related to endothelial dysfunction. Structural abnormalities include arterial remodeling, which with intimal and medial wall thickening, and perivascular fibrosis and capillary liquefaction, often in the setting of increased LV mass. So these structural changes are well documented in conditions like hypertrophic cardiomyopathy and hypertensive heart disease. And in these conditions, adverse remodeling leads to thicker vessel walls due to smooth muscle hypertrophy, collagen deposition, and variable intimal thickening. And remember, these remodeling processes tend to be diffuse and involve the entire left ventricle. So now, why CMD important? As you may know, the clinical presentation of coronary artery disease has changed over the past few decades. So up to 70% of patients undergoing coronary angiography for angina have no obstructive CAD. And this scenario is referred to as ischemia with non-obstructive coronary artery disease, INOCA. And now we recognize that CMD is one of the mechanisms responsible for INOCA. So this is the data from ischemia trial. So among participants enrolled in ischemia trial with moderate or severe ischemia, the prevalence of INOCA was actually 13%. They have shown that INOCA was associated with female and younger age. Importantly, the severity of ischemia was not associated with severity of non-obstructive atherosclerosis. And it is also known that the CMD plays an important role in many cardiovascular conditions, such as heart failure with preserved ejection fraction, and hypertrophic cardiomyopathy, Takotsubo syndrome, and post-PCI or post-CABG angina, and aortic stenosis. So therefore, evaluating CMD would be very important for managing these conditions. And most importantly, coronary microvascular dysfunction is related to worse patient outcome. So this is the data from recent meta-analysis showing that microvascular dysfunction is associated with 4 times increase in mortality and 5 times increase in MACE. So therefore, the patient with CMD should be detected and managed properly. Okay, now how can we diagnose coronary microvascular dysfunction? To date, there is no established or standardized diagnosis strategy for CMD. But we have a couple of options to identify CMD. Invasive coronary angiography with functional testing has a 2A recommendation in the 2021 ACC/AHA chest pain guideline. And non-invasive tests, particularly PET and cardiac MRI, also have a 2A recommendations. So now let's walk through each modality. So as an invasive assessment, coronary angiography can exclude obstructive CAD, but it is also useful to evaluate coronary microvascular dysfunction by assessing the coronary slow flow phenomenon. So coronary slow flow in the setting of non-obstructive CAD is considered a surrogate of CMD. Here is an example of coronary slow flow, which suggests the presence of CMD. So as you can see here, contrast washout is also delayed. However, the recent article published last year denied the association between CMD and coronary slow flow. So this should be further evaluated. The flow measurements with intracoronary wire is the most established method. So hyperemia can be achieved by injecting adenosine or papaverine into coronary arteries. So this can be performed with either a pressure thermistor tipped wire or Doppler tipped wire. So both can measure coronary flow reserve, and typically 2 or 2.5 is used as the diagnostic cutoff. Finally, intracoronary provocation test is essential for the diagnosis of coronary vasospasm, both at the epicardial and microvascular level. And typically, either acetylcholine or ergonovin is injected into the coronary arteries, and then ischemic ECG changes, and then reproduction of typical angina are assessed. So this is an example of epicardial coronary vasospasm. There is no significant stenosis at baseline, but you can see diffuse stenosis after ergonovin injection. So soon after the injection, the patient complained of angina with ischemic ECG changes. So a few words about key parameters for invasive CMD assessment. The coronary flow reserve, CFR, and index of microcirculatory resistance, IMR. So CFR is essentially a ratio of resting coronary blood flow to maximal hyperemic flow. IMR is defined as the product of distal coronary pressure and mean transit time of saline bolus during maximal hyperemia. It's important to remember that CFR represents both epicardial and microvascular function, whereas IMR represents microvascular function only. This is an example of CFR and IMR measurements. Although there is no obstructive CAD is identified on coronary angiography, CFR is less than 2.0 and IMR is greater than 25, which is indicating coronary microvascular dysfunction. So now we will move on to non-invasive assessment. So currently there are 5 options: so echo, CT, MRI, PET, and SPECT. So please keep in mind that PET is the most validated and clinically available, whereas the other modalities are less available and mostly used for research purposes. In terms of echocardiography, there are 2 approaches: contrast echocardiography and transthoracic Doppler echocardiography. So contrast echo uses microbubble contrast, which allows to quantify myocardial blood flow by assessing microbubble velocity. But there are very few validation studies for coronary microvascular dysfunction. Alternatively, transthoracic Doppler echocardiography can be used, and you're going to measure coronary flow velocity at rest and during stress in proximal segment of LAD. And it has been shown that this method correlates very well with invasive measurements. Here you can see an example of coronary flow measurement by Doppler echo. The mean diastolic velocity is evaluated at rest and during stress. And coronary flow volume reserve, CFBR, is calculated as the ratio of these 2 measurements. And CFBR less than 2.0 is considered as coronary microvascular dysfunction. Overall, echo is cost-effective and radiation-free method, but it's highly operator dependent and affected by the patient body habitus. So next, the CT is also an option. A big advantage here is that both coronary anatomy and perfusion data can be assessed in a single study. However, coronary flow quantification is only possible with dynamic perfusion scans, which significantly increase the radiation dose. Additionally, there is a concern that the contrast may cause vasodilation, which could lead to an overestimation of flow measurement. So this is the case of a 54-year-old woman with typical angina. So as you can see on the left panel, coronary CT angiography confirmed the absence of significant stenosis. However, CT perfusion on the right panel shows globally reduced myocardial blood flow, which is consistent with coronary microvascular dysfunction. So although CT perfusion is promising technique, its clinical adoption remains limited due to high radiation exposure and contrast dose. In addition to CT perfusion, so there is another potential CT parameter to assess CMD, the ratio of coronary lumen volume to LV mass, so-called VM ratio. The coronary lumen volume and LV mass can be estimated by using post-processing software. And yet it has been shown that there is a correlation between invasive FFR and VM ratio. And additionally, the Vancouver group has shown that patient with microvascular angina has a significantly lower VM ratio. So VM ratio could be a useful indicator of coronary microvascular dysfunction. The cardiac MRI also enables measurement of coronary blood flow using rest and stress perfusion imaging. So no radiation required, and spatial resolution is excellent. And disadvantage here include high cost and limited availability and limited applicability to patients with implantable device and claustrophobia. The biggest advantage here is that MRI provides a comprehensive assessment of cardiac anatomy and morphology and functionality and myocardial perfusion through a variety of sequences. For example, the cine images provide accurate functional assessment for both right and left ventricles. And T1 mapping and LGE sequences will help you identify the non-invasive characterization of the myocardium. So therefore, MRI would be useful if the patient has CMD with underlying infiltrative or structural heart disease, such as hypertrophic cardiomyopathy and cardiac amyloidosis. This is a case example. So left panel shows normal case with stress flow above 2.0 in almost all segments. And coronary angiography confirmed the absence of obstructive CAD. The right panel shows abnormal case where stress flow is globally reduced. And coronary angiogram confirmed the presence of multivessel CAD. A recent multi-center study showed that quantification of myocardial blood flow can detect obstructive CAD more accurately than qualitative analysis in CMR studies. So blue line is showing the diagnostic performance of qualitative analysis. And when stress MBF in yellow or perfusion reserve in red is added, the diagnostic performance improved. So however, it should be noted that availability of CMR is very limited and absolute flow quantification has not been used clinically. Okay, let's move on to PET imaging. So PET is currently the gold standard for non-invasive assessment. The PET has good reproducibility and diagnostic accuracy with extensive prognostic data. So let's look at PET-derived myocardial blood flow, MBF, and myocardial flow reserve, MFR. So first, it's important to remember that several factors can affect the quantification of MBF. That we need to consider the radial tracer, the pharmacologic stress agent, and the PET system itself, as well as the post-processing software. We also know that biological variables such as age, sex, and genetics can change flow values. What about the repeatability of these measurements? So actually, it's very consistent. Listing MBF has a variability of about 0.2. And as for hyperemic MBF, the same day testing gives a coefficient variation of around 10%, rising to 15 to 20% for different day measurements. So when we talk about the cutoffs for CMD, the most centers uses hyperemic MBF cutoff somewhere between 1.7 to 2.3. MFR below 2.0 is widely accepted as indicating CMD. However, some studies suggested that a more strict MFR cutoff of 1.7 or even 1.5 may carry stronger prognostic information. So let's talk about hyperemic and resting MBF. So hyperemic or stress MBF reflects both microvascular and epicardiovascular performance. Reduced stress MBF may indicate early structural or functional problems in the epicardial or microvascular compartments, even without obstructive CAD. And in terms of resting MBF, it is determined largely by oxygen demand. Conditions that increase heart rate or blood pressure, wall stress, or sympathetic tone increase resting flow. Whereas hypertension, lower heart rate, or athletic training decreases the resting flow. MFR or myocardial flow reserve is the ratio of stress flow to rest flow. So this shows how much the coronary arteries can increase blood flow. At rest, coronary flow is largely stable due to autoregulation. Under pharmacologic stress, however, flow becomes directly depends on perfusion pressure. A reduced MFR can occur if resting flow is too high or if stress flow is too low. So there are two other flow parameters that we often include in our report. Late pressure product corrected MFR, RPP corrected MFR, and coronary vascular resistance, CVR. The corrected MFR is the hyperemic flow divided by resting flow, corrected for the patient's late pressure product. So this method cancels out workload-driven variation in resting MBF. But it should be noted that this can mask clinically meaningful increase in resting MBF. So coronary vascular resistance, CVR, is calculated by dividing mean or systolic arterial pressure by MBF. Because CVR takes into account coronary driving pressure, CVR provides a more accurate measure of microvascular function than simply looking at blood flow. So, okay, let's talk about interpretation and reporting. So when we interpret classical myocardial perfusion images, normal perfusion findings in the setting of normal LV size and normal LV function generally excludes significant epicardial stenosis or high-risk coronary artery disease. So this is the general rule. Next, we quantify myocardial blood flow and look at the myocardial flow reserve. So we can find four main scenarios. So number one, normal stress flow and MFO, indicating intact microcirculation. So number two, both stress flow and flow reserve are reduced, suggesting diffuse CAD or classical coronary microvascular dysfunction. So number three, the normal stress flow but reduced flow reserve, often because resting flow is unusually high. So this is potentially due to hypertension, tachycardia, or hypermetabolic status, or normal variant. And number four, lower than normal resting and hyperemic flows with preserved MFO. So this is usually linked to a lower hemodynamic state, like athletes or beta blocker use. A few words about interpretation nuances. And it's essential to evaluate factors that may change or mask our interpretation. For instance, age-related changes can cause mild decreases in stress flow that might be normal for older people. And similarly, same patient can become non-responders to vasodilator stress if they consumed caffeine before scan. So this makes it challenging to confidently rule out severe stenosis of diffuse CAD. And coronary artery calcification, which we can frequently detect on the low-dose CT, also provide crucial context. So in the setting of reduced MFR, few or absent coronary calcification increase the likelihood of a severe microvascular dysfunction, whereas moderate to severe coronary calcification raises suspicion for advanced coronary artery disease. And it's also important to note that global MFR or global MBF can mask regional variations, which potentially masking focal area of reduced flow. So let's look at some case examples. So this is a 75-year-old woman with exhaustional dyspnea. So rest and stress rubidium PET was performed. So as you can see here, perfusion images showed normal perfusion at less than stress, and also the gated images showed normal epi bore motion. And the stress MBF here was moderately reduced, 1.32, and the MFR was mildly reduced, 1.62. So coronary CT angiography showed minimal non-obstructive coronary atherosclerosis. So these findings are consistent with coronary microvascular dysfunction. Here is an example of reversible CMD in Takotsubo syndrome. So this patient had a typical apical ballooning wall motion abnormality in the setting of acute chest pain. So coronaries are normal, and LV gram was consistent with Takotsubo cardiomyopathy. And PET in acute phase showed a reduction in stress flow and flow reserve, as you can see on the left panel. And then whereas in the chronic phase, the stress flow and flow reserve significantly improved. The stress flow was 1.99 and the flow reserve 1.83. And this reversible flow parameter on serial PET imaging seen in this case may support, so one of the possible mechanisms of Takotsubo is coronary microvascular dysfunction. So this reversible, flow parameters seen in this case may support this idea. The last piece is SPECT. Similar to PET, the SPECT can be used to quantify myocardial blood flow. Although a new generation camera is required, there is growing data to support the accuracy and good reproducibility of the measurements. The SPECT is more widely available compared to PET and CMR. SPECT may have potential to play an important role in CMD in the future. So this was the first validation study for SPECT myocardial blood flow performed by Dr. Wells, Dr. Reddy, and colleagues. So the results showed very good correlations for global MBF and flow reserve measured by SPECT versus PET, regardless of use of attenuation correction. So these are time activity curve acquired with SPECT and with PET in patients with LAD stenosis. The top panel is SPECT and the lower panel is PET. The red line is showing blood pool activity, and blue line is indicating myocardial uptake. The fitted model data is in light blue. As you can see here, the SPECT and PET curves are very similar, and polar maps showed similar results with reduced uptake and flow in the LAD territory. More recently, SPECT MBF has been shown to have prognostic value in CAD patients. So this is the data from 122 patients with chest pain who underwent SPECT MBF measurement. So Kaplan-Meier curve showed that MFR below 2.0 was associated with worse outcome. And I'm expecting the SPECT data on CMD to be available in the near future. Okay, lastly, I will talk a little bit about treatment options for CMD. So to date, there are no specific treatment recommendations due to the lack of robust evidence from large-scale trials. However, the main goals of CMD treatment are to reduce the risk of adverse cardiovascular events and to improve anginal symptoms. So atherosclerosis targeted therapies include aspirin, statins, ACE inhibitor, and ARBs. The statins and ACE inhibitor ARBs are reported to improve endothelial function and CFR. Anti-anginal medications include beta blockers, calcium channel blockers, and newer agents such as ranolazine or ibablazine. So these medications may help relieve symptoms by improving coronary flow reserve or reducing myocardial oxygen demand. In terms of non-pharmacologic therapy, aerobic exercise, weight loss, and smoking cessation were reported to be beneficial for CMD. A recent topic for coronary microvascular dysfunction treatment is the coronary sinus reducer. So this device consists of a metal mesh device pre-mounted on a balloon catheter that is hourglass shaped when expanded. The coronary sinus reducer is designed to increase venous pressure and distribute blood flow from non-ischemic to ischemic lesions, so thereby reducing ischemic damage and angina symptoms. A recent paper showed that coronary sinus reducer improves angina, quality of life, and coronary flow reserve in patients with microvascular dysfunction. So this is a small study with only 30 patients, but coronary sinus reducer could be the potential treatment in the future. So finally, I would like to briefly discuss our ongoing research project on inspiratory muscle training. So currently, Dr. Chow and myself are conducting the BREATHE trial, which is a randomized control trial to investigate the effect of inspiratory muscle training on coronary blood flow. We expect that this training may be an option for patients with angina, particularly those with coronary microvascular dysfunction. So we are completing enrollment and preliminary results will be available soon. Okay, in conclusion, coronary microvascular dysfunction arises from both structural and functional changes in the coronary microvasculature. And it occurs in various cardiovascular conditions and significantly affects clinical outcome. So several imaging modalities are now available to measure myocardial blood flow in patients with suspected CMD. And PET is the most validated and clinically available non-invasive imaging modality. To develop targeted therapies for CMD, the further studies are needed. So finally, I would like to thank all of my supervisors. That's it. Thank you.
Thank you so much for the excellent overview. Are there any questions, Dr. Chi?
That was a fantastic overview, thanks. I have a practical question with regards to the adequacy of the vasodilator response when you do your PET scans. I've noticed in the report that there's mention of the hemodynamic response as well as the spleen-liver ratio. My question pertains to how is there a sort of standardized process in which you interpret that and make your subsequent recommendations, including sort of caffeine abstinence or and repeat testing. And then related to that is the use of regadenoson instead of dipridamol with the caffeine effects. Is that available in Canada? Why is it not being used if it is?
Thank you for a good question. I think it's very good question. So as an imaging fellow, the hemodynamic response when assessing PET is pretty important, and then I think there are two approaches that we are currently used. So one is hemodynamic, changes, particularly blood pressure decrease and heart rate, increase. So if there is enough blood pressure drop by 10 millimeter Hg in systolic blood pressure, we think there is response. And also we should consider heart rate increase by 10 when stressed. So blood pressure down and heart rate increase would be the one clue to assess the hemodynamic response. The other one is the splenic shutoff, which can be assessed by PET imaging as well. So currently we don't have specific or standardized cutoff to assess splenic shutoff. So I think one of my colleagues, one of my fellow is investigating the appropriate cutoff value for splenic shutoff. So I think that's the key parameters to assess the appropriate response to pharmacological stress. So maybe Dr. Binlands or Dr. Chow can add some comments.
So just very quickly, if there's a hemodynamic response, we know that they've responded, right? So you typically see a heart rate increase of 10, blood pressure drop of 10. The problem is there's I would say they're less reliable. So if I put you in a PET scanner, you're claustrophobic, I give you a drug that makes you feel unwell, your blood pressure can also increase, right? So I would say if there's a hemodynamic response, that's useful. If there isn't or it's partial, I would say it's less useful. The splenic response is actually quite reliable in terms of visual analysis. So dipridamol, adenosine, they actually cause vasoconstriction of the splenic vessel. So we see splenic constriction, or no, I'll take that for us as a very good indicator that they've responded. The problem is that some individuals partially respond or fully respond, and that's very hard for us to determine. So, splenic response, I think, is very useful, and it's very useful when there's very low MFR values. and there's no splenic response, in which case we think that the low MFR values are falsely low because they didn't respond to the drug stress. To answer your regadenoson question, so it's $1,000 a dose. So in the Canadian system, we cannot afford it. The Canadian market is so small, the company that actually sells it made a conscious decision not to market it in Canada. However, GE has picked it up, so they actually have made it available, but no one's bought it because of the cost.
$14.
Exactly. Yeah.
So if someone does not have a drop in systolic and like what are the cutoffs for recommending scan caffeine, and do you actually measure caffeine levels?
So interesting, someone is doing a project on caffeine levels. So I personally go based on splenic response. Hemodynamic response is useful if there's a blood pressure drop and heart rate increase. More importantly, symptoms. So if the nurses document patient had headache, was having chest pain, for us, that's very useful because you know the drug has actually worked. The problem is with the new system, it's not always apparent as to where it's documented. So it's hard for us to know. So we use these surrogates, but spleen, I would say it's like 99% of my decision making, hemodynamic response less so. But we've shown, the problem is we've actually done research here and shown that there's prognostic value. Like a normal scan without the hemodynamic response is different from a normal scan with a hemodynamic response because there are some individuals that haven't fully responded to drug stress, and we may be underestimating disease in some of those individuals.
Yoshito, great talk. Thanks very much. I'll just make a couple of other comments and maybe questions. How are people trying to distinguish diffuse atherosclerosis from true microvascular disease? Did you come across that?
Yes, I think it's very important important questions. So one clue would be like coronary calcification, calcium scan. If no calcium, I would say it's likely, pure or, mainly coronary microvascular dysfunction. If there is a lot of coronary calcium on low dose CT, that would indicate the diffuse atherosclerosis with or without coronary microvascular dysfunction. That's my understanding. But I think it's very tough to precisely distinguish between the two based on the measurement.
I think the CT helps for sure. The other thing is, I think that there is variability, and we've just talked about the problem with dipyridamole and caffeine, which I think Dr. Tabusi's study will help. They're studying 600 patients with caffeine levels, so we'll get a better sense of the impact of that and so on. But with the variability, I think it's still important that we have the invasive and non-invasive when we're trying to make the decision whether somebody truly has it or not. So using all the information to be able to get an answer for the patient. The other comment I would make is two things. One is about the cutoff of 2.0, which is really actually been arbitrary, right? It was actually the FESC, the Scandinavian group, basically published on a cutoff of 2, and others had used 2 before, and it kind of evolved. But it never really has been tested as this is truly the cutoff for microvascular disease, depending on the technique you're using. And we know that young people may have, if a young person has a flow reserve of 2.2, like that's a problem, right? They should be sitting at 3 or 4. So I think the age factor, you did bring it up, but taking that into account and taking it into the whole picture, which is why I think getting the resistance measurements on those patients is going to be important as well. And then the other piece is that and this is a personal bias, that I don't think we've seen patients with taking out the people who are non-responders with flow reserves like really low, 1.4 or below, less than 1.5, with isolated microvascular disease. They often have diffuse obstructive atherosclerosis. At least that's been my observation. And in some of our previous work, the people with those levels of flow reserve were the ones who actually died in the sample set. So just another piece to potentially keep in mind in interpretation.
Nice talk, Yoshito. There will be a follow-up talk for those who attend the Rare Diseases Conference on 28, because I've asked one of the speakers to be deliberately provocative, saying that PET should be the gold standard and to be a wire-based assessment. But my response to Dr. Pinlan's and your question about whether we can differentiate diffuse coronary disease versus microvascular disease in the invasive world, we can get an indication if the FFR is normal, but the CFR is not. And then there are also instances where the CFR is borderline, as Dr. Pinlan alluded to, that 2 is sort of fairly arbitrary. And we've had patients where the CFR is 2.4, 2.5, but the IMR is 45, 60s. So we know those are true microvascular disease. My own skepticism is that whenever we do these studies in invasive methods, it is said that 75 to 90% of the time, when we do the full study, including acetylcholine provocation, it's abnormal. And everyone attributes it to endothelial dysfunction. And as you said, attributed to hypertension, diabetes, dyslipidemia. So then, do I need a test to tell me that you need to lose weight, you need to exercise, you need to be treated for your diabetes, blood pressure, and cholesterol? Those are the difficult things. And also the last comment I'll make is that I've actually insisted in our own invasive protocol that we do differentiate between epicardial spasm versus microvascular spasm. And the way we do it is we give the dose of acetylcholine to induce spasm. We reverse it with nitroglycerin. We give the same dose. And if the patient has recurrent chest pain and ECG changes, that's microvascular spasm.
I see. Thank you for the very important comment. I have a question for Dr. Chung. So how often can we apply the comprehensive, invasive functional testing without like obstructive disease? So I mean, in my mind, the FFR or like such functional testing is often applied to, moderate disease or, significant disease. And it can be difficult to apply this comprehensive testing to very minimal or mild disease.
When we use the Coronary system, if your FFR is normal, then we use an uncorrected IMR. There's lots of studies done to validate that. But if you have in the presence of moderate coronary disease, if your FFR is lower, less than 0.8, say, then there's a correction factor. And then on the coronary, this is one of the slides you showed, is what CIMR is for. So that's when the FFR is not entirely normal. So it's FFR is not one when we do it with the sensor and the disability. Even in a completely normal vessel, FFR is not one. It's actually done in the Japanese population. It's actually 0.94. So with the sensor at 2/3, 1/3, it is 0.94. It's normal one.
Got it. Thank you.
And the other thing is we are also measuring caffeine levels in the
I have one question for you. Your BREATHE study. So can you just talk us through your hypothesis? Is it that by strengthening your inspiratory muscles, you have a higher negative intrathoracic pressure that's like transmitted to your coronary vasculature? Or is that your hypothesis?
Yeah, our hypothesis is that the prior studies have shown that so this training actually improved the endothelial function in the different randomized control trial. So we assume that if this training can improve the coronary endothelial function, this could eventually lead to the improvement of the this kind of inocar or non-obstructive angina, angina with non-obstructive CAD, and then, but we recruited abnormal patient as well as normal patient. So our study is just pilot study. So I think we have to expand our idea.
Great, thank you so much. Are there any other questions? Great, thank you so much for the presentation today. It was a great review. Please sign up. Please sign up.